This is Dr. Stone-Gale, and this lecture is going to be on the various skin cancers that you may see in primary care. The first one we're going to look at is squamous cell carcinoma, and squamous cell carcinoma is a malignant tumor that does originate from the keratinized epithelial cells, and it can invade the dermis, and occasionally it can metastasize to distant sites. So avoidance of excessive sun exposure is an important factor to prevent these type of skin cancers. They're mainly seen in men and older individuals, with 80% of the non-melanoma skin cancers occurring in patients over 60 years old. And the majority of the reason for this is because over the years of sun exposure, it just builds and builds and builds. And this is about the age group where it starts to rear its ugly head and you start to see it come out. Even though there are times when it will present itself at an earlier age because of the fact that there's been excessive sun exposure throughout the person's lifetime, such as if they live in California, they live in Florida, they live in Texas, somewhere where the sun is so hot, you may see it occur at an earlier age, but 80% of them are usually in the age frame of 60 years old. When you're looking at what actually squamous cell cancer looks like, it is a rough, scaly area. The patient will usually tell you that it's been there for a while. They haven't seen it heal at all. And when they try to scrape it off, it starts to bleed. So that's one of the concerns that you have, is that the patient will tell you that. It also can take on like a heaped up appearance, and it may show that there are some flaking to the lesion that you may see. Usually these are going to be seen on the lips and the tips of the ears, as well as the nose, the upper cheeks, and in bald men, you'll see them on the scalp. In women, the shins in women seem to be more prevalent, and also the women, you'll see it more on the hands and the forearms. The most common presentation, as I said, is that firm papule with that scaly, rough surface. And sometimes you might see these show up on patients and they kind of resemble like a horn, and they have like a hyperkeratotic and a red base to them. When you see later on, the surfaces of the squamous cell carcinoma lesions tend to bleed easy, and sometimes they will turn like a reddish brown hyperkeratotic color and get redness around them. Okay, risk factors. Let's talk a little bit about risk factors. With these patients, they are usually very fair skinned. They have blonde hair, blue eyes, or they may have red hair. And they'll tell you that they've never really been the type of person to tan before. So they just seem to burn. They've had some type of cumulative sun exposure. Maybe they work outdoors, they work in construction. They may have been sunbathers years ago. Indoor tanning devices also, definitely increase the risk of squamous cell carcinoma or any type of carcinoma. And these you may see in younger people who say, well, I was exposed years ago. I used to go to the tanning bed all the time. Someone who also has ionizing or UV radiation therapy for cancer, or PUVA treatments for psoriasis, excuse me. Okay, as we move forward onto basal cell carcinoma, this is a malignant tumor that is non-melanotic, and it originates from the basal cells of the epidermis. It is very slow growing. It is locally invasive. It does not usually metastasize, and it is the most common malignancy that you will see, accounting for about 75% of all skin cancers. Rarely does basal cell result from basal cell nevus syndrome, which is an inherited autosomal dominant disorder. Patients with this disorder do tend to have multiple sites of basal cell carcinoma at a younger age. And we really don't see many of these in primary care, but I just wanted to bring that up to your attention. When we think about the most important risk factors, obviously, for basal cell as well as squamous cell, it's always going to be the skin cancers are typically seen in older adults and elderly adults. With the basal cell carcinoma, you see the Caucasian, the very fair skin, the Irish, the Scottish, the Scandinavian, the German heritage, and people who are living in equatorial latitudes. Once again, the similar to the squamous cell and also with melanomas are the 60 years of age and older, and usually they're seen more in the male genders than they will. Men are twice as likely to develop this and 3 times as likely to get squamous cell cancer as women do. So some of the risk factors for basal cell are very similar to the other cancers, the other skin cancers. They're very fair skin, they have that sun exposure, the indoor tanning, and they have actinic keratosis, which is associated with about a 1.5% rate of progression to basal cell in these high risk patients that have the basal cells occurring over 4 years. There are several forms of basal cell carcinoma which are seen clinically. So they may be nodular, they may be sclerosing, there could be some superficial forms. The nodulo-ulcerative type is usually the most common type. And there's usually a well-differentiated tumor cell, and that may extend from the dermal epidermal interface into the dermis and the subcutaneous fat. But rarely does it penetrate very deep. These are superficial. And you can also see these where they may present similar to a dermatitis, and they look like they have a reddened border around them and a scaly red border with a fine rim. And I'll show you a picture of that as we move through this. Okay. This is a picture of a squamous cell, and this is a picture of a basal cell carcinoma. So as you can see, the basal cells typically appear in areas of the skin that are chronically exposed to the sun, so face, eyes, ears, cheeks, nose, the neck, and you can see that they have that kind of a cratered looking appearance. They may have like a light colored pink center. They may have some crusting around the edges, or they may have like a what do you call it? Like a variegated color, such as blue, black, brown, but they do have that central ulceration, which is seen usually in the later stages of a basal cell. The squamous cells, which are found usually on the lips or the tips of the ears, the nose, the cheeks, the scalp, especially in men who are bald, and in the shins of women, these present more with a firm papule. It has a scaly, keratotic, rough surface with irregular borders, as I talked about in the previous slides. And they may bleed easily. Typically, the lesion of the Bowman's disease appears as a solitary nodule, and we don't see that too much in primary care. You see that more if you're working in a dermatology practice. Okay, so let's move on to the melanomas. Now, melanoma is something in this course that we're not going to get real in depth with, but we are going to talk about it because I think that it's important that you're able to possibly recognize that there may be something going on with your patient that you need to refer to dermatology for, because these people will come in and they will actually have lesions that you're going to need to look at. And you're going to need to know if you need to send them out or if you can treat them in the office. And the majority of these, you're going to really have some good idea on what they look like, and you're going to have to probably send them out to dermatology. So as we look at melanoma, these are basically tumors of the melanocytes, and they are found in 95% of cases on the skin. They may also occur in other sites. So you may see it in the eye. It's possible that it can be seen in the intestine. It's possible that it can be seen in the brain. And this is a very high aggressive form of skin cancer. So when you see something on the patient that you're suspicious about, it's very important that you go ahead and refer that patient out. There are types of melanoma that are superficial spreading, which is in about 70 to 80%, and they're characterized by an extensive lateral or radial growth before you see a vertical invasion. They could be nodular in about 15 to 30%, where you see just that vertical growth. You may see lentigo maligna, which is at 5%, where it's an in situ form that may persist for years before you see that vertical extension of it. And then in 2 to 8% of the cases, there may be an acral lentiginous, which is a particularly aggressive form. It's more commonly seen in darker skinned patients, and it appears on the hand and feet. So although the majority of skin cancers in the United States are basal cell or squamous cell, melanoma is, if it's discovered early enough, it can be, even though it's a very fatal form of cancer, it can be cured. But if it does extend beyond that 4 millimeter in depth ratio, then the prognosis is very poor. So it is an aggressive tumor. It's important that you diagnose it early. 50% of these cases occur in patients between 35 to 65 years of age. It may appear to be cutaneous, and they may have a genetic mutation, and there could be possible relation to sun exposure. So there's a couple different, causes for it. You can't just say that these patients were exposed from sun over the years, because there's been many known cases where sun exposure has not been involved in this at all. But we do know that one contributing factor, as we talked about with squamous cell and basal cell, is the use of tanning beds in these younger patients, because just one indoor tanning session has been estimated to increase the risk of developing melanoma by 20%. And if you have each session in additional years, in the same year, additional sessions in the same year, it increases that rate by another 2%. So it's very scary when you think about the patients who do go to these tanning booths all the time. There has been research that's been into the genetic component of melanoma, and the presence of dysplastic nevi has found a relationship between family history and the development of melanoma. So the finding of a dysplastic nevus, one or more atypical moles, or any other type of skin cancer, such as your basal cells or your squamous cell cancer, can increase your risk of melanoma. And when you think about the number of moles, or we call them nevi, but you can call them moles also, that normally peaks in the young adulthood age with the 20 to 25 years of age, and then increases after 50. So a large number of these nevi on an individual who's older than 50 years is considered to be a very strong marker for increasing their risk of melanoma. And they do believe that about 7% of the white population has at least one atypical that they would see. So family history, we talked about the presence of large or multiple, and this is your highest predictor, so keep that in mind. Also, patients who are immunosuppressed can have the potential to get melanoma, and your exposure, which we talked about. And once again, any of these skin cancers, you're fair skinned, you're freckling, you have blue eyes, blonde hair, red hair, that all puts you at an increased risk, and as well as blistering sunburn as a child. It's so interesting when you go to the beach and you see these children with, the parents have them out in the water for hours and there's no block on them. And I had a friend who was just telling me the other day that they were at some function and her daughter got blistered, sunburned. And I just was, it just like made my skin crawl to think about the fact of this child having the potential down the road to get a melanoma. Pediatric overexposure to ultraviolet rays, especially a history of one or more sun blistering burns before age 20, has a dramatic increase in their risk of developing melanoma. So years goes by, 30 years, 40 years goes by before these things can come up, but unfortunately they're present. So when we talk about melanoma, we talk about the ABCs of melanoma. And sometimes they're even staged a little differently, or they're staged differently too. And we're going to talk about that in another slide. But when you think about the ABCs of melanoma, you're thinking about looking at the asymmetry. What does the border look like? Is it irregular? Does the color variate within that same specific lesion? Is that diameter over 6 millimeters? Does it evolve? So does it change in size? Does it change in shape? Does it change in color over time? So looking and doing a really thorough physical examination on these patients is critical to this. The nail beds, looking at the nail beds or subungual melanoma can be observed in older patients, and that's most commonly found on the thumb or the great toe. So, not just looking at their skin, but we need to be also looking at their feet and their hands. So we have a 7-point checklist for melanoma. We're looking at the size, we're looking at the shape, we're looking at the color, but the minor features we're looking at, and those are the big major features, the minor features that we're really looking at are the size of it. Is it inflamed? Is it oozing? Does it change in sensation? So is it painful to the patient? Are they saying it's uncomfortable? Those are some of the 7 points that we need to look at when we're looking at a patient with melanoma. So we want to suspect melanoma in lesions with any major feature over 3 minor features or over 3 minor features. And you can do a skin biopsy if you're uncertain of the diagnosis, but that's usually not done in primary care. Usually with these patients, if you're going to suspect something, you're going to go ahead and refer them out and let dermatology manage them. Because a high index of suspicion is necessary, because it often is really hard to look and say, is this a atypical nevi, or is this a melanoma, or is this just something normal going on? So if you suspect possible melanoma or a dysplastic nevi, then you need to be referring to dermatology and letting them, see what's going on. If it's discovered early enough, and this is the key, if it's discovered less than 4 millimeters in diameter and with superficial involvement, the chance of a complete cure with excision is good. So it really depends on the staging, and talk a little bit about the staging. My husband just had a stage 0 melanoma that he had removed off his back the other day. And what they actually do is, when it's called an in situ melanoma, which is stage 0, it has not invaded down and penetrated below the skin surface. So it was caught extremely early, but I can tell you it didn't even have the suspicious look of a melanoma, and which is a scary thing. These stay very localized. They're not invasive. So what they do require a margin excision of at least 0.5 centimeters. So they'll go ahead and take out at least 0.5 centimeters all the way around that area. The melanomas measuring less than 2 millimeters in thickness require at least a 1 centimeter circumferential surgical margin, and the thicker tumors at least 2 centimeters in margin. So it's really going to depend on what the dermatologist thinks the margins need to be, how much they need to be cut. The thickness or the depth of the melanoma is one of the critical factors when we're looking at determining both prognosis and the choice of therapy. So there's a Breslow depth classification system that's been used as a prognostic factor, and that is complemented by a Clark staging system of the tumor invasiveness. So as we look at this slide here, we're looking at the Clark's staging system. So as I said, the stage 0 is in situ. The stage 1 has invaded the skin and the small and is small, but it's non-indurated, and it's growing at a very, very small rate. So you want any of these you want to have removed. This stage 2 is more localized, and it's larger, and it could be ulcerated, and these are considered intermediate, where your stage 3 and 4 have usually already metastasized to some other area of the body, and there's subdivisions that are within those stages. So as you can see, this can be a very aggressive, and it can be a very aggressive very quick. So we want to make sure to get these patients to dermatology as soon as possible. If you get into the stage 3, it may not have spread to a lot of the organs, but when you're in stage 4, it's usually already gone to the lungs and the brain. So stage 3 and 4 can metastasize, definitely. Okay, and this is a picture of a melanoma, and you can see the regular borders, the variation in the colors, and so this gives you just kind of a good idea of something that you can just kind of put in your mind's eye. We all know about prevention of skin cancer. You know, the Skin Cancer Foundation has definitely come into looking deeper and deeper into how we treat patients and how we prevent skin cancer. Recommendation is to stay in the shade. We know the hottest times are between 10 and 4 p.m. Avoiding the burns, making sure that you're not using tanning booths, making sure the patient is using cover up with clothing, especially if they're out working in the yard, they're mowing the yard, that they have a broad brimmed hat on. There are now hats that have UV in them that are really good. They're expensive, but they're really great hats. And make sure that when you're ordering sunglasses, to get UV blocking sunglasses. I do have one of our office workers does have melanoma in her left eye, and it was because of years of never wearing sunglasses and living down here in Florida. Using very broad spectrum sunscreen with an SPF 15 or higher every day. They do say that sometimes if you get over 50, it's not even worthwhile to spend the extra money to do that, but who cares? Do it anyway. You want to make sure that you're at least getting 30, if you're going to be outside for any length of time, sitting at the beach, working in the yard, whatever. And applying at least 2 tablespoons to the entire body before you go outside, and then reapplying it. And this is where people get into trouble. They apply it before they go outside, but they don't reapply it after they've been sweating or swimming, so it's gone. There's nothing there. The United States Preventative Service Task Force states that the current evidence is not sufficient to assess the balance of benefits and harms of using a whole body skin exam by a primary care clinician or patient skin self-exam for early detection of cutaneous melanoma, basal cell cancer, squamous cell skin cancer in the general adult population. But they do recommend counseling children, adolescents, and young adults aged 10 to 24 who have fair skin, and about minimizing their exposure. Now, in retrospect, in addition, the American Cancer Society recommends screening every 3 years in people 20 to 40 and yearly for people over 40. And I can tell you that going to a dermatologist and not having them telling you that you don't need to have skin evaluations done probably wouldn't happen, especially in specific areas that you live in. But, that is the recommended guideline. Now, I have to tell you, those are only guidelines. That doesn't mean that has to be done. Those are only guidelines. And when I'm doing a physical exam on patients that do come in for their yearly physical, I do a thorough exam on their skin when I'm looking and making sure. So you just have to kind of use your own judgment with that. And I would be more comfortable doing a skin exam than not doing it. And I know when people go to the dermatologist every year, they do very detailed skin exams, even looking in between the toes and on the bottom of the feet. So that's something that I think that they're not going to really get away with not doing